I'm Dr. Neo Chu An from Pintong Christian Hospital, Taiwan. Today, I will talk about the proposal guidelines for ICS Surgical International Humanitarian Service. We have been invited to WHT to presentation of what we do for the humanitarian service years ago. The World Health Assembly resolution say that the strengthening emergency and essential surgical care and anesthesia as a component of the universal health coverage. And that's why we need to promote international surgical health service to remote area and countries. We need you to join us. Surgery must be a core part of healthcare, even in the poorest countries. There are so many surgical professionals in the United States, but so less in Tanzania. So surgically treatable condition kills 17 million people each year. That's more than tuberculosis, malaria, HIV, and AIDS combined. So 5 million people have no access to safe surgery, and surgical outreach to children are more or less. So recent global health advocacy had focused on surgical system strengthening as a component of university healthcare. This has been brought to the forefront with the publication of Global Surgery 2030. So we lack of a lot of these surgical team and operation. The evolution of surgery humanitarian missions need around the world, and not only operation but also teaching of surgery to improve healthcare worldwide. The quality of care in humanitarian surgery is very important also. Best practice guideline on surgical response in disaster and humanitarian emergency was reported in 2011. And you say that it is a lot of things that we need to know and prepare, for example, security, electricity, waste management, water, sterilizations, anesthesia equipment, etc. And these are all the things that we need to prepare. And humanitarian surgical mission guideline for successful anesthesia support also very important. But no guideline for surgical humanitarian service during peaceful time yet. These guidelines are based on the review of the best available information and clinical practice experience of ICS humanitarian health service in various countries and areas. Given the high level of surgical expertise Taiwan has achieved, Professor Aji Kwan believes it's time for the country to adopt less humble profile in international medicines. Taiwan breakthrough neurosurgical research and microsurgical reconstruction, etc., for example, made the country a world leader in those fields. Professor Aji Kwan thinks that rather than just acting as a provider of Medicaid, Taiwan could walk out of Taiwan and serve as a role model for other advanced countries as they develop their own related humanitarian health service program to the third world. Professor Aji Kwan says that a neurosurgery, microsurgery experience and know that the Taiwan surgeons accumulate over the years now make the Taiwan ICS the leader in the third world humanitarian service. This becomes our slogan and motivation to bring lots of humanitarian health service to every corner of the world that needed surgical help. The Taiwan International of Surgeons, since established as a resource for surgical aid program abroad, Taiwan could also do more to help patients living in foreign countries who require surgery treatment. Since 2012, we have go to many islands of Indonesia, an area where there are no surgeons. And from the process, it teach our young doctors to learn a lot of knowledge, what they will never learn from their medical university. We are so happy that many Indonesian surgeons touched by Professor Kwan's loving movement tell us that they wanted to go back to the service of these countrymen recover from the treatable surgical disease and injury and trauma. Since then, also besides Taiwan ICS, multiple national teams like Poland, Malaysia, Indonesia, and China have joined us, serve wholeheartedly to various countries and needed areas around the world like Indonesia, Peru, Poland, and Mongolia. After our various ICS humanitarian health service, those patients would appreciate towards us, and that emotional touching would last a long time. We set the ICS guideline for humanitarian surgical mission requests for humanitarian surgical services during the peaceful time. The request for humanitarian surgery service can come from various sources. They can arise from individuals working in the third world country, from institution which has a specific need to upgrade service for surgical department, or direct requests from a health ministry. Occasionally, the request can come from a non-government organization such as religious or service organization. In the vast majority of cases, as shown in the survey, requests come from individuals or government or private institutions. It is important that humanitarian service should take place in response to a request for aid and not out of personal desire to carry out altruistic humanitarian work. So, organization of a humanitarian service in response to a request, the response to a request depend on their need and surgical specialty, and establish a medical resource available for both local and what we can afford to provide them. Funding of an humanitarian service is very important. This is perhaps the most challenging part of organizing an humanitarian service, because the team need to be transported to whatever the request has come from. Supply and medicine has to be purchased depending on the type of mission surgery specialty to be carried out. Organizing a team and team composition. This will considerably be the nature of requests. Most surgical teams will consist of surgeons, anesthesiologists, and nurses. The team leader is usually chosen by consensus because of his or her expertise, and not only in his surgical specialty but also leadership qualities. During missions in a foreign country, it is sometimes inevitable that the team may have to deal with the emergency situation like shortage of water and electricity, transport difficulty, and even sudden onset of a local conflict where evacuation of the team may be needed for safety reasons. The members of the team must be chosen to care because of a cohesive team is an important factor for the success of the mission. Unexpected challenges sometimes arise in the midst of the mission, and the team has to be able to respond in unison to overcome this adversity. The issue of bringing medical students, trainees, and volunteers and lay people is also important. The protection of the team member is most important. The countries visited by humanitarian surgery team are usually in the third world and known epidemic of malaria, dengue fevers, and other emergent viral disease. The team leaders need to find out at least the latest health report in that country to be visited. Team members needed to be correctly advised to taking appropriate health precaution. In addition, they should be covered medical insurance as well as travel insurance. Quality assurance and outcome documentation. This is an important aspect of humanitarian health service, has not been sufficiently emphasized. There's a need for humanitarian service to be accountable to the donor and recipient institution to make sure the expectations are met, and to be accountable in the event of medical legal complications. The QA measures are the best implemented when they are self-imposed to all individuals, and team understanding that they have an unwritten ethical obligation to ensure the safety of patients treated by them and during an humanitarian surgery service, and to the total responsible to their actions. Surgeons on humanitarian mission are invaluable, engaged in noble cause, but good intention alone cannot ensure success. The principle of non-malfeasance, often defined as the obligations to do no harm, must be rigidly upheld under all conditions. Medical initiative automatically focus on what and how to provide appropriate medical surgical care. Equally imperative is what not to offer. We have to be aware of the risk of conducting a mission that provides temporary short-term solution but fails to take and intake pictures. These are the things that we should focus on, like medical indication, patient preference, quality of life, and contextual features. These are the things that we have done so far. Provide surgery is not the only solution. Surgeons know more than surgical knife, also pathophysiology and the root cause of disease, like taking care of the diabetes foot. So the principle of non-malfeasance or do no harm equally imperative in what not to offer and what to offer. So these are the things and reported by in the newspaper. Education and training during the humanitarian health service is also important. The aim should be directed, enhancing, assisting the program rather than to create something new. The capability of the local staff being trained should be carefully assessed, and the training too should be practiced in local setting. And the methodology, training, and skill transfer will rely mainly on the hand-on training in the operating room and less on the didactic lectures and the tutorial. So not only continue donation of equipment, but maintaining and preparing personnel also required in the ICS team. For our ICS Humanitarian Health Service, we come out with guidelines for this service, a checklist. First, a request comes first. Go where there's identified need and where you and your surgical expertise are wanted. Expertly establish a clear goal and priority by developing the type, frequency, timing, and duration of program in a real partnership with the local individuals and institutions. Ensure that there is a close liaison with those hosts and clearance with the local government authorities and medical organizations, and the local surgical team provide meaningful opportunity for them to provide critical feedback and ensure that feedback is incorporated into planning of future programs. Strategically recruit volunteers to understand the importance of working as a team and who want to share their skill and knowledge. Source volunteers within your institution who are familiar with the regions that your team is going to, leverage his or her language and cultural familiarity. Ensure that volunteers as well as briefing and understand what is accepted and required of them, including cultural briefing might be different from your country. Our ICS guideline to ensure that there's a code of conduct in place where there's a clear understood and adherence to by the entire team of volunteers. Encourage maximum host surgical team participation in service and education and training activity. Ensure personal health and protection all team members. Ensure quality of care through a multidisciplinary approach and have experienced specialty on the team. Training is directed to the local staff personnel and not inexperienced surgical trainees on the local team. Local staff centers beside the patient centers perform proper post-operative care and long-term follow-up of patients wherever possible by trying to ensure continuity over time of the team members. This is very important as it builds trust and relationship. Use of informatic technology to accumulate data for better care and follow-up in the future's mission planning. So this is in Ambon, and you can see that need to travel to remote unknown countries and areas, and these are those travels that we have done, and it's important that we go as a group and to ensure there's training and protection. So is a thing that we have done so far. You can see that is a lot of patients and a lot of surgeons and students that come with us, and we are actually very happy. So it is important of volunteers in the service team knowing the local cultures and language, and important of them knowing of local culture and language is very important to successful of the team. You can see that we go everywhere to different countries, and it's such that we have gained a lot of important experience, and upgrading our service and new informatic technology also important. So upgrading service, and also neurosurgeon can play the role of pharmacist. Do what you can to help is most important of all. Thank you.